Onc Live Insights is a video editorial program produced by Onc Live.
Bone marrow transplantation or allogeneic bone marrow transplantation at the times that we are experiencing, or the times that we are living with these new drugs in CLL is a very, very important topic. And of course, the approach in general is that with the new drugs, many groups are starting to really abandon early referral to transplant, or at least start to really think which are the most important group of patients or characteristic of patients who still will make them eligible. So in my opinion, and in general, I will have to say that truly the incorporation of the BCR inhibitor are really dropping dramatically the referrals to transplant. However, I think it's important to start to identify a subgroup of patients, relapsed refractory CLL, who may have very specific characteristics such as TP53 mutation with or without deletion of 17p, in combination with a very complex cytogenetics. These two risk factors may really confer this patient a high risk of progression after starting BCR inhibitors. And in my practice, it's still the patient who at least I explore the possibility, depending on the age of the patient, the availability of donors, the possibility and the exploration of allogeneic bone marrow transplant. Of course, ultimately the decision is from the patient and from the doctors in an individualized situations, and the possibility that this therapy may offer a long-term control of this condition. So these days, I think there is, in the past, we used to really refer patients with 17p or TP53 mutation at diagnosis. I think there is early data, but seems that BCR inhibitors such as ibrutinib in the front line may really confer a beneficial effect, and maybe those patients has less risk of progression. However, in the second line, and when these factors that I mentioned before, like such a complex karyotype, are present, I think will be a good opportunity at least to send patients for a consultation and for a honest discussion about the benefits and the risk benefits of this procedure.
The role of stem cell transplant in CLL has changed dramatically in the last couple of years. The prior indications generally included deletion 17p in both a frontline or relapse setting, or short response duration to prior chemoimmunotherapy. Now, with the efficacy of ibrutinib and idelalisib in these patients, this has been significantly revised. Personally, for those patients with the highest risk deletion 17p and/or a complex karyotype, who we know have a shorter remission duration on ibrutinib, in fact, for 17p, it's a median of 28 months, so only about 2 years in the relapse setting. Those patients I still refer for consideration of transplant. Many of them are not necessarily interested in transplant because they're feeling great and their disease is under control on the oral inhibitor. The problem is that we know that at the time of relapse, it can be difficult to salvage these patients. So I, to some extent, try to further stratify them in terms of what I perceive their disease risk to be, based on the number of prior therapies, the response to those therapies. For example, a patient who's been given FCR is refractory to FCR in the setting of 17p deletion worries me more than one who had a couple years remission and is now relapsed. And so those types of disease risk factors, as well as, of course, patient risk factors, obviously the age of the patient and what other comorbidities they have, will significantly influence their risk of transplant. There's also the issue of whether a good donor can be found or not. And so all of these factors come into play. I still have a lengthy conversation with my cytogenetically high-risk patients with 17p about the overall value and what's known about ibrutinib and idelalisib, the relatively short follow-up, the potential difficulty of salvage at relapse, versus what is usually an upfront risk for a longer-term benefit of transplant.
Now we have ibrutinib and we have idelalisib. Both of those have clear activity in patients with 17p deletion and have significantly improved their survival. And so we don't routinely send patients to transplant in their first remission, and it's somewhat controversial as to when we would consider sending patients to transplant at this point. There's morbidity and mortality associated with transplant. It's a difficult treatment. It's a long-term commitment for the patients in terms of their treatment. And since we have such good outcomes with these new small molecule inhibitors, we are tending to push back transplant further and further and using it later and later. The one piece of data that maybe has been a little bit useful in terms of identifying patients who we would think about transplant perhaps a little bit earlier in their small molecule inhibitor treatment course is patients who have a complex karyotype on standard metaphase karyotyping. Our work and the work at The Ohio State has shown that patients who have a complex karyotype have a shorter progression-free survival on ibrutinib. And so that may be a marker for more aggressive disease and disease that may not be able to be held in check as well with the small molecule inhibitors. And it would be that patient population that we'd say, okay, well, maybe we need to have them evaluated for their donor status and sort of introduce the idea of transplant a little bit earlier because we're nervous about how they're going to do even with the small molecule inhibitors. We have ibrutinib, we have idelalisib, and there's another drug called venetoclax, which is a oral small molecule inhibitor of BCL2, and that also has activity in treating patients who are fludarabine refractory and who have 17p deletion. So I just named 3 treatment options, and theoretically, patients can go serially from one to the next as treatment options. And so you can see and appreciate that if those agents all have activity in treating patients with 17p, perhaps transplant never gets considered or discussed, even for the highest risk patients who we've identified as those with 17p.